Hi everyone, welcome back, we're just going into the afternoon session. So what we're going to be doing this afternoon is actually going into the commercial framework. So from the conversations this morning, it was very clear that a number of themes came out. So it's clearly a difficult and complex system that we're dealing with, but there was a very important quote that came out from Andrew by Amy Abernethy. We should not be scared off by doing the hard stuff and thinking it's someone else's job. It is our job, and this is important. Second point was that public and patients being involved in decision-making results in better decisions. So absolutely crucial that we have this as a core part of things. And I think the case has been made for the variety of different values that come out of working with data. Money is only just one of these. Transparency also came out as a very core theme, and it's a key ingredient to trust, and that's something we're going to be dwelling on this afternoon as we go into the commercial framework. There was also a very important theme about no one organisation can do this alone. This was stressed many times by many of the speakers earlier on. So fantastic, we've got NHS, fantastic, we've got the different hubs, but we're going to all have to work together in partnership on this extremely important issue. So it's important we take practical next steps to actually and use the hubs as practical exemplars that are really wrestling with these decisions, have got the complexity of different issues to work with as good examples. And we need an approach that evolves and allows us all to learn as we go through it. So what I'm going to do is step through some aspects of the commercial framework, and the groups will break out to actually discuss the different aspects of that. As I mentioned earlier, the hub, there's three core parts to the programme. We've got the Alliance, which actually is about making the data, bringing the data custodians together and building common principles around them. We've got the research hubs, which then are about improving and enhancing the data, make it usable for researchers and innovators, and the Gateway, which creates a portal that allows discovery and enables access to the data sets. All focused on meeting user needs, be they from researchers, industry, academia, NHS, government, charities, all different use cases on there. And that very important feedback loop to the patients and public benefit that allows us to have trust in how the data is being used. The hubs had a variety of different use cases, different diseases, different purposes, so from eyes through to cancers, to Discover Now using real-world evidence, to the pioneer aspects of acute care. So the variety of different uses means we need a variety of models to accommodate those uses. One of the things we're doing through the Health Data Research Programme is actually setting up a series of principles for participation in the infrastructure. We've heard the word principles used a lot this morning, and it's key. These are really important components of actually setting up the ground rules for how the engagement can happen and aligning behaviours and intent across the different custodians. So, for example, at the top of here, we need to be demonstrating active and ongoing engagement with patients and the public. And secondly, all custodians need to be encouraging the availability and use of data for research and innovation that serves the public interest. I won't step through all of these. These are all very much available online, and everyone has signed up to these different set of principles. But principles are not enough. We actually need to some practical steps that allow us to the hubs to develop a practical ways of working that we can all trust in. And we believe that we need to have a practical framework to meet four different needs. First of all, we need it to be able to promote public trust through providing a transparent way of showing what commercial arrangements there are. Secondly, we need to be by having a consistent and clear method, it actually enables data access and enables a more positive user experience rather than having to deal with a variety of multitude of different contracts and different arrangements. Thirdly, it ensures that the commercial arrangements actually serve the public interest. We can ensure that's baked into there. And then fourthly, that by having a common language, we can enable organisations to collaborate and learn and share more readily because of the commonality from there. The gateway is absolutely crucial. So by having the data sets accessible and discoverable through a common portal, we can actually put in the commercial framework into the gateway. So we can actually, for each individual data set, we can start showing what are the commercial arrangements, what are the terms and conditions, and this is a fantastic vehicle to make transparent, that key principle, transparent to different people how data is actually being used and what the arrangements are. And then behind that, so the framework we need to put together is actually different components of that we want to put through. And that's what we want to test this afternoon and what we'll be gathering feedback on. So there are two broad parts. There's the commercial aspects in terms of getting transactions associated with fees and charges associated with use. And then there are aspects associated with outcomes. So and on the use side, there's obviously the aspects associated with per data use, so as you access data, and there's a variety of different variants on that, be that from the frequency of use to the types of users to the type of data they're actually receiving. The second column then is around the data services they get. So in addition to data, there's value-added services people are receiving, and there's a variety in how those might be charged for. And again, by user, by service type, or by time it takes associated with the service provision. And then on the right-hand side, these are outcome-based activities, either associated with cost savings from the organization who's using the data as they realize cost savings, how that is being shared back to the data custodian, and or the share of revenue. So if they realize revenues and benefits from that, how that is shared back. So on the cost side, then maybe you may want to lock in an aspect of cost savings that you realize a proportion of that in the future. Or you may want to be looking at actually discounted services. And Piers gave a good example this morning around actually discounted services for the organisation, free of charge services associated with that. And on the final column around share of revenue, there's actually, you might be looking at royalties, you might be looking at profit shares. So as an organisation derives benefits going forward, how that's shared back, how the NHS, how organisations benefit from that. These variants show there are a range of different possible options an organisations might consider. And they might consider multiple ones from each of these columns. We're not looking for one size fits all at this point for various different reasons. And in fact, what you see, this isn't new, organisations are doing this already. They tend to be more based in the use-based side, on the left-hand side of it, but some are doing things also starting to go into the outcome-based, those longer-term, potentially riskier revenues and outcomes coming from that, such as Genomics England is starting to look at that. The models will vary on different strategic choices that organisations make. So an organisation needs to think through what are the sources of sustainability, what do they have, what are the variety. It doesn't need to necessarily just be through this financial aspect, it might have sources from other funds. They also need to consider what type of public benefit is trying to seek through the business model. For example, are they encouraging innovation, or are they looking for more short-term financial benefits back to the NHS? There are varieties on that. And finally, who can access the data and what are those access guidelines? That also will shape the type of benefits and things on there. But most importantly, under all of this, it's essential, crucial that patients and public advisors are closely involved in the strategic decision-making as they develop their model and as they work with the appropriate regulatory bodies, such as the HRA, as part of that. It's absolutely key. So, groups are going to be working on two different questions. First of these, we want to be working on the types of use cases. Given the types of use cases that we're looking at, we'd like to hear back what are the benefits and risks associated with this, and have we missed any important elements in there? So, considering that model. And secondly, how should we engage with and involve members of the public, patients and practitioners in the ongoing development of this model? This is not just a one-shot action. We're going to be learning and evolving as we go over time. So how does that feedback happen? So looking forward to hearing the feedback and thoughts you have coming back from that. Thank you. So what we're going to do now is just play back from each of the groups. Just going to hear back what things and themes are coming out to see the degree of commonality, whether there's some common themes coming across there. What we're then going to do is you're going to bail out another coffee, and we'll be pulling the themes together for the last session, which will follow with John and Andrew on that. So first of all, I'm going to invite David.
Thanks, Caroline. So I worked with the Green team. We had a great conversation. I think broadly speaking on the framework, the feeling was that it was comprehensive and had the advantage of allowing a choice and blending of elements depending on the data set that was in question. Mike's not working? Not working at all. So while we fix that, I'll just say that I work with the Green team.
No, you're going to have to wait, I'm afraid. Sorry. Hello? Yeah, you just need to, I think, speak louder and closer.
Can you hear me now? Is that better? Okay, I'll put it closer. So the Green team felt that the framework was comprehensive and had the advantage of allowing choice and blending of the different elements depending on the type of data set that was being used, the type of data user. So it was very flexible and comprehensive, and felt overall that those were advantages of it. In terms of the risks or the things that were missing, it wasn't felt so much that there was anything around the framework itself, but the context. So there was obviously nothing in the framework about the more broad type of public benefits from use of data, which is obviously why the data is being used in the first place. There was nothing about the other elements of how value is returned to the data custodians, for example. So elements which are not meant to be in the framework, but do need to be placed around it, if you like, to contextualize it. And there's also concern that the language needed to be absolutely right to ensure there was no misinterpretation more broadly of the framework. Then in terms of patient and public involvement,
On again. Do you want to give a different one? Thank you. Thank you. Low on battery.
Then in terms of public and patient engagement, there are a number of really good points that were made. first of all, that using the public itself to communicate to the public is very effective, and so finding ways to do that is critical. Also giving data back to the public about how data is being used and how effective it is, creating concrete use cases, concrete examples, very powerful. Making sure that all the methods available to get to the public and patients and get their involvement, not just patient juries, for example, but digital methods of outreach, exploring all of those is very important. And making sure terminology is right, clearly, and also investing in training and support to ensure that patients, public practitioners are able to understand the issues and engage with them and provide meaningful guidance is really important. So those were the conclusions from the Green team.
Thank you. Over to Ben.
Thanks, David. So thank you. So we were the pink and/or lilac team, squirreled away in the basement. We had a great discussion, such a great discussion that we didn't even get on to the second question. So I think, yeah, lots of talking about the challenges and potential benefits and risks of the framework. So I'm going to start with some of the points about additional elements or missing elements from the framework. One of the things that came up was the idea of share of risk. So there's a lot of talk in the framework about share of benefits, but actually in terms of sharing liabilities, that's something that commercial partners would be interested in. As David mentioned, the sort of intangible or hard to quantify benefits, so things like training, reputation, education. I think some of the points that Pierce made in his talk earlier about the benefits to Mirfield in terms of people joining from far afield. So that's a difficult one to capture. The possibility of a subscription model, so not just for a specific transaction or interaction, but over a longer period. And then again, as David said, some of the other wider context beyond the framework itself, so about share of benefits within the partnership or beyond, and the context of other funding routes, so work with other public bodies. So benefits, if it's done right, it would level the playing field for SMEs, so reducing the amount of work from legal input and other experts involved in those interactions, so really supporting work in that area. And also by potentially making the process more straightforward, that allows for more sustainable public funding, so more investment in the hubs. Also the opportunity to increase transparency and the common language, allowing the development of shared expertise between the hubs and beyond. Then some of the risks in the time frame available, particularly with the hubs looking at becoming sustainable within 3 years, that makes the right-hand side, so some of those longer-term areas, more challenging and might sort of push the thinking towards the left-hand side of the framework. One of the risks brought up about accessibility for citizen scientists, so that looking quite like a commercial approach, and that might put off some of the, not perhaps SMEs, but individuals looking at undertaking specific research. Transparency, while a benefit, also a risk in terms of the level of openness to potentially at what point it undermines commercial sustainability by bringing out too much sensitive information. And then the final point about legality, in that even if the entire framework is supported by agreed contracts and is fully legally permissible, actually being legally acceptable is necessary, but it's not sufficient. So about going above and beyond to ensure that we bring the public along with us and that it's fully supported. Thanks.
Thanks, Ben. And David.
Thank you. So the red team performed exceptionally well, as you can imagine. Really, I think there are a number of points that do overlap, so I won't dwell too long on those, but I think there are also a couple of issues or points that came up that I have not heard mentioned yet. So firstly, around the benefits, there were sort of three things that were identified. One was the fact that actually having this opportunity to operate as effectively a sort of hybrid model, combining both outcome and cost recovery, was attractive and seen as a real positive. There was also a flip side of that, though, which is obviously with that sort of hybrid model, you can get increased complexity, so risk associated with that side. Another point around outcome-based pieces introduces more of a partnership rather than transactional mindset, and that was seen as a real potential positive on that piece. And then a third piece was a really important point about how do you actually track those outcome-based ones through the system, where it can be quite a long period of time and the line of sight can change quite considerably. And how can you use regulators to effectively trace the watermark on the data for new innovations and software as a sort of intervention, so that those can be tracked through, so actually you can get that return at the end of what could be quite a long process. So some real clear benefits, but a good number of risks were highlighted. I think that focus solely on the financial aspects is a financial both from a perception and reality point of view. We also had a point around the perception of it being called a commercial framework, that it was only relevant to transactions with commercial organisations as opposed to representing all sort of transactions, regardless of whether that was with academic institutions, the NHS, and other organisations as well. A real feeling that there's a danger around cost recovery models, particularly where you've got high upfront costs or you've got a lot of cost to recover, that it can become a real barrier to entry. And there was a comparison here with this sort of tissue bank situation, where if you're not careful, you set the price too high, demand falls to the floor, and you don't recover any monies at all, and it's a real barrier to seeing that asset being used and delivering value beyond the financial. And then I think the final point on that was really that the risk of managing those outcome-based approaches and the challenges associated with that, and particularly one around the equity share and how that would sort of mind you towards having exclusivity arrangements so that you do obviously maximise your return on that particular equity share, and it drives different sort of dynamics and behaviours. Risks mostly covered, what's missing. I think the only thing, again, is that patient perception of value, particularly picking up the non-financial piece, and then also how decisions on sustainability are made. So not necessarily missing from the framework, but they're missing from the context around the framework. How will we judge whether hubs are sustainable? Where is it purely a sort of revenue line and a cost line, and making sure that one's bigger than the other, or otherwise? Sorry, patients. We got to the patients, public and practitioners. A few different points on that. So just grab those away. We'll pick it up later. Firstly is very much the need for a segmented approach. So public patients and practitioners are different groups, and while some things will be relevant across all of them, which is a meaningful role in the decision-making process, the actual communications and the approach to those groups need to be segmented and different. Particularly hard-to-reach groups are obviously important to think about and work on, and there's work going on within National Voices and the Health Foundation around that level of representation. The need for that sort of a broadcast and an ongoing dialogue communication with the public overall to counteract the sort of one-off stories that will inevitably come to light. The need to include researchers as practitioners. And the real benefit, or one of the real benefits of having patient, public, etc. involved is that it drives a plain English conversation amongst technocrats.
Thank you. And Andrew and Carol, just any additional things we've got from other groups, and that'd be great.
So I'll be very brief, although the yellow group was outstanding. So reducing complexity, this is seen as an opportunity for the UK to reduce complexity, because one size doesn't fit all, but reflecting on Anne-Marie Naylor's report, there's so much variation out there, and Jackie suggested, could we look at a model just like the Lambeth boilerplate suite of agreements, which aren't fixed, but that gives you a starting point, so a suite of templates. Secondly, learn from what's out there. There's some great practice in IMI. Also, we had the benefit of a US observer, the Orion network of public sector cancer providers in the States has sort of done this, so we should reach out and look at Orion. Thirdly, this emphasis on the NHS, wider benefit to the NHS. You know, convergence of care and research means NHS benefits, and we really need to root this. And lastly, there was had a very wide-ranging discussion. Look at other models like the Ordnance Survey Met Office relationship of how open is data. So that was an interesting comment. And lastly, realism. This is complex, and we need to learn as we go and be transparent as we learn together. And on the patients and public engagement, absolute clarity that we need to be much better at feeding back to patients who's doing what with information, why, and what's the outcome. Secondly, engagement with adjudication, with practitioners. And thirdly, the importance of use cases. We don't have enough, so we can't do enough in that space. But we had a great discussion. Thank you.
To Carol, thank you.
So I won't compete about who had the best discussion, but it was obviously Blue Team. So some common themes, but there was a set of themes around communication and language. So again, what does commercial mean? And we recognise that universities had spin-outs, that commissioners could be running a business. So we thought that the hub exemplar was perhaps narrowing us in thinking about these sort of all third-party uses, and that we might want some models that took that into account. The second thing that we talked about was transparency in the first principle, and whether you could pick and choose about transparency in relation to things about commercially sensitive charging models. And I think the view was that we couldn't, but there was still some issues that might be commercially sensitive, depending on whether you had a kind of tiered model of charging that you could point to and say this agreement was perhaps made under that. But it was unclear. So the second question about language was the meaning of the term public interest, and who decides and what are the criteria for public interest, and how we align that with the discussion this morning about better health outcomes and more, using health data, patient data specifically for health, and how you were able to communicate that. And when we then came to the framework, there was a feeling that there were some problems in separating use versus outcome-based models, that these might be problematic to communicate to the public, especially defining outcomes and getting the public to understand outcome-based care in an NHS setting. There was also a concern in the charging process as to how the public would understand the difference between licensing and selling, and that we didn't have a solution quite for that. We recognise that intended uses could be on a journey to better patient impact and outcomes, but might need some explaining. And one example was that getting data for NICE submissions, would the public understand that that was a valuable thing in its own right? So there needs to be a lot of good thinking about the communication with the public. In general, there was support for the principles, but we felt that if you were using the hub as use cases for this, that we needed actually to have an agreed set of use cases that really tested some of these red lines, and that currently it was difficult to see what those would be from your list, Caroline, but perhaps that some more thought on that. And a planned evaluation that would report back would be thought to be useful if we want to move this, use the hubs as a way of moving this along. But a point was made that there was not real clarity about where the framework sits with NHS trusts, for example, or GP federations who are data controllers, and in particular issues not just about where the data access decisions are made, but also about where the commercial value might be returned and how that would be operationalised. I hope I've caught everything that everyone raised. And then turning to our discussion on members of the public, I think we felt that the principles didn't really make a strong enough point about the partnership and engagement with the public, which we all thought was really important, and also health practitioners. And where we'd like to see them is on the data access committees, and to recognise that you needed to follow involved principles, that these needed resourcing and building into the sustainability plan. We obviously are not being representative of the publics in that, so the things like the citizens, juries and so on may be a concurrent methodology, and the example of the NICE approach in using citizens juries, which is actually referenced in the MS report, is really important, and Angela can talk more about that. We also felt that that this is quite a challenging task for the public. It's one thing to be asked your opinion, it's another thing to be asked to help decide on things, and that raised a whole set of training that might be more specific around health data science. And I think there was some discussion in the lunch with Hilary Newis, who I think has gone, about what sort of organisation could perhaps provide that. Hilary, you might want to say more about that later. And that we needed to see citizens' juries as powerful but distinct from data access committees. And then a final point is, if we want health professionals in, we have to recognise that to get general practitioners in the room, who are an important target audience, we also need to buy out a session of their time and give, obviously, all clinicians notice. So I think that's been something where in North West London they've been grappling with that and trying to involve. So it's really important to have a health professional voice in this as well. I think that's everything.
Fantastic. Thank you all very much for all your contributions on there. What's going to happen next on that is that what we're going to take is all the different areas. So you'll notice there are people scribing and capturing different areas and drawing those together to then actually bring forth what the kind of key points and things are coming out from that. The frame, I think what I'm hearing from there, though, this kind of concept of transparently using the gateway to make that transparent, make it clear, that did seem as though there was general support for that, which is very helpful to hear, with noting a number of aspects in terms of caveats and things around there. But I think that sense of actually making things transparent, making the public be able to be aware and be involved, engaged in this is absolutely crucial. So thank you so much for your thoughts on that. We're going to have now a brief break, and we'll be back in here at 1:45. But what we're going to do is then have a working session after that, of actually as a group in a plenary session, which John will be leading from there. So thank you all so much for your time.
Last session, and it falls to me to try and I underline try, and integrate some of the hub feedback and just give you a brief collated summary, and then we'll open that up for questions and comments and anything that you think is missing. And after that, I'll give a few final reflections before handing over to Andrew Morris, who is going to try and interpret all of this in terms of the next steps that HDR UK, as the body really which is charged with delivering against this agenda, will try to achieve. So firstly, on the hub feedback, I think there's a general sense, having been through the notes, that this is a comprehensive framework. It's avoided the temptation of being over-prescriptive, and I think that's important because it enables a degree of flexibility and acknowledges that within this complex system, learning and reiteration of the model will be important moving forward. That said, I think there is also a sense that there could be benefit from, for example, a suite of model agreements or arrangements that all hubs might start with, even if they're evolving distinctly. A blended approach involving both the use and outcome framework came through in a number of the reflections. And then a final plea as a general statement about avoiding increasing the complexity of what is already a very complex set of arrangements. So I'm always taken back to the situation we got ourselves into in relationships to clinical trials, which required then the creation of the Health Research Authority to try and make sense of that. And there is a danger if you try and overprescribe and bureaucratise to lock everything down, that you make the system so rigid it can't possibly function effectively. In terms of the missing elements, comments were made about the need to include ways of risk sharing as well as value sharing. That's very much part of the negotiation when one enters into contracts with commercial partners. Integrating within that, within the system, the patient perception of value, which of course has to inform our discussions at every point. And then greater clarity about what international access agreements will look like. It's hard enough to think about how we articulate this for UK agencies, but we inevitably will already are creating resources which are perceived as international value, and what the arrangements are for those types of relationships needs to be thought through. As far as risks are concerned, well, many people referred, and I've already referred to the complexity. There's also a risk in poor communication or use of language in getting these concepts and ideas across to the public. We're going to have to become very adept at articulating what we mean, particularly in relationship to this sensitive commercial environment, and finding ways of actually involving members of the public in articulating what we mean could be one way through that. Another, I think, very significant risk is that of sustainability. It was pointed out in my group that there aren't many innovations such as this which become sustainable within a matter of a few years, and yet the expectation is that somehow that's what will happen. And we have to acknowledge that with the state of digital maturity to underpin the quality of what we're trying to achieve here, that there will have to be continuing long-term investment, and of course that applies to curation of data in the long term as well. And that raises the issue as to whether we can simply rely on one-off deals or whether there is a requirement for some form of subscription model, which could be tiered according to capacity to pay or scale of enterprise, to enable some of that core infrastructure to be provided and create a sustainable platform moving forward beyond the initial grant period. The caveat that legally acceptable activities may not be socially acceptable, so we do need to we can't simply rely on conforming to statutory requirements. We have to test things against the societal viewpoint at every turn. In terms of benefits, then over and above the sort of straight financial benefits, I think great emphasis was made of some of the more intangible but nonetheless very important benefits, such as a breakdown of silo working that comes from hubs sharing experience, bringing all of the various partners involved in the hubs together, which will have a benefit. It will have a benefit economically and in health terms, even though it's difficult to quantify. And the same is true with something that Andrew referred to in the first session, which was about the creation of a learning health system. It's well recognized that if an institution is involved in research, then the clinical outcomes for that institution are better than for those comparable institutions that are not. Now, that's nothing to do with the direct result of the research itself, there's some form of cultural dividend, some form of reflective practice that comes from being exposed to evidence and considering it that has a real value over and above the research itself. And the same would be true, I would argue, with the use of data in the way we're describing. It would fuel continuous quality improvement in those institutions that are involved in its acquisition and use. And that's an indirect benefit, but nonetheless, in some ways, I think it might turn out to be culturally more important for the health system than the direct return in commercial terms. The point was made that creating the framework and creating the hubs helps develop more of a level playing field where smaller and larger commercial partners can play against agreed arrangements. And finally, if one goes for an outcome-based system, there are some inherent strengths in that, in being able to track the commercial value of products and services, which may have a bearing on the regulatory interactions as well. So a rather crude summary of a very rich set of discussions. I hope I've captured at least some of the important points, but I want to open it up now for the audience, for you to contribute, give us your feedback, any comments that you'd like to make, anything that you think has not been sufficiently emphasised in those hub discussions. So please, questions or comments, I should say. Richard, could you just get the microphone, Richard, so live streaming can benefit?
Yes, Richard Barker, thank you, John, and thank you to John and Andrew for organising this fantastic meeting at a great time. Let me just say in the larger group what I said to both of you individually, which is I think we might be in the process of making a semantic error in always talking about data. Because if you talk to me as a citizen, say I've got plans for your data, my hackles immediately rise. What this is in large measure about is about learning. And you say, do you want the NHS, do you want others to learn from the experience of treating you? You ring a whole set of different bells. So whilst we're actually in a room like this, doesn't matter, because we all know what we're talking about. But when we're out there, I think we need to think very carefully about semantics. Yep. And I suggest the word learning as an example. The second point I'd like to make is about the international landscape. So I'm fortunate enough to see the international landscape in China, in the US, in Europe, and so on. There is a real competition, a real marketplace for this. And I think I know the way the UK normally operates. It's extremely rigorous, extremely comprehensive. And in 5 years' time, we will have the perfect framework, the single access point, blah, blah, blah. In the meantime, some of the systems I talked to in the US who have slightly fewer qualms, but they're not cavalier, will have put in place all the things that we're talking about here for very sizable groups of people. I mean, the Vanderbilt Health System has 2 million people, 10-year data, very well curated. That's just one example. So as we work through this, I think we need this very international perspective on the race that we're in. Some collaboration internationally, but also the international marketplace and the international race.
Thank you, Richard. Two very good points there. Please, Angela.
Yeah, I strongly support the idea of taking an international look. I'm Angela Coulter from HDR UK's Public Advisory Board. I've recently been involved in assessing projects for IMI, and there's some really interesting projects across Europe that are very much touching on this agenda, so we mustn't assume it's just the US. There's a lot going on, and I think we can learn from it, and indeed share learning with it. Indeed.
I think just in terms of the speed issue, I mean, I think it's a truism that whenever you get a bunch of partners and they're each concerned about their own risk, the risk framework seems to be set by the most risk-averse element. And we saw that with clinical trials where when you were trying to do a comprehensive clinical trial agreement across a number of institutions, that the most risk-averse could slow up the whole process. So I think it has to come in the culture that we need to be agile and decisions on risk made at a high level where people are willing to take responsibility for those decisions. Please, other questions and comments? Somebody that...
Thank you. I just want to add that also future-proofing is important to incorporate sources of data that are not just NHS and public type, right?
Absolutely.
So thinking about private data collection or equipment and manufacturers, many of the innovation will be out there. And we have to think about this, especially on the alliance front, how we can easily plug those in and integrate with existing hubs.
Indeed. And it came up this morning, but I think when you start to integrate more of the data that informs the social determinants of health, your environment, your behavior, your living and working conditions, some of that becomes extremely personal and sensitive. And so, again, integrating that will need to take particular care. Please, who was next? Gentleman over there.
Wasn't sure to whether to ask you or Andrew this question. Kind of Andrew to invite me here. While I agree with Richard that you have to learn from the international system, I live in the US. I've seen an awful lot of attempts at very similar models being tried, and they failed miserably. You have a lot of advantages here. You're a single payer, single provider system. You have some of the best data available anywhere in the world. I think time to market is going to be the key. This is a great model. I'm not sure that if the number of people in HDR UK are all dedicated, they're all different jobs and so on, and time frame, from what I read, was allocated for a couple of years. The long-term sustainability of this organization to have real impact in a relatively short period of time is the one thing that I would say. How do you overcome that? That's a big challenge. This is not an easy thing to do. So time to market is going to be the key.
Yeah, I agree with that. And I think, Andrew, you'll probably pick up on some of the practical implications of next steps in the final session. Who's next? Yes, please, Mark.
James Peach from the Cancer Data Hub, DataCan. I think there's, looking forward to 10 years, it's almost impossible to think of a future where we do not have a dynamic consent, where the individuals in the NHS make active choices about their data and their data use. At the moment, we don't have that, and I think some of the discussions are assuming this shouldn't be the intent. So I need to make sure that, I don't think as an individual cancer hub we can do it by ourselves, but together we need to get to a position where everybody has actively chosen to share their data for the cases that we are trying to push it forward now.
And of course, it is a dynamic process in the sense that people's minds will change, as indeed we saw with care.data. The world had moved on because of external circumstance, and the view on privacy and data was much more toxic. Please, a question in the corner. Comment?
I think, sorry, Michael Messenger, Leeds Centre for Personalised Medicine and Health. I think just to add to the point that James was making as well, I think part of the challenge and risk of a sort of informed consent model for everybody is that will exclude a large percentage of our population from gaining from the benefits of health data. And actually, I would imagine that's the population we most want to help using this data. So we have to balance the risk of informed consent with increasing health inequalities and to bear the risks and benefits of both of those in mind.
Yeah, it's a very good point. Please.
Carol Longson, the ABPI. I just want to draw on this international comparison competition. Again, reflecting on some of the conversations I've had, but maybe trying to tie in a couple of the observations that have been made today. One of them struck me really between the eyes is the absolute essential collaborative model that is necessary to get over the hurdle of realizing the benefit of the use of health data. So the example that we have with Moorfields, I think, exemplifies that. It wasn't any one party or jurisdiction that could do that on their own.
No, no.
So that's the first thing. The second thing is there is absolutely a international competition to gain the interest of the life science industry in coming and doing this type of work in different countries. Mm. And so if you're thinking about trying to tie those two together, you can't do it alone, and there's a competition. One of the things we probably need to do sooner rather than later is, instead of this slide that I had that put up, in a sense, what problems existed with the access to data, we need real use cases from the hubs and from the exemplars that demonstrate the pace of change that's happening.
Right.
So I would absolutely love to be able to put up a slide that talks about the things that have already happened in
Yep.
2 or 3 months since the start of the hubs, and start to build that narrative that starts to turn the heads at an international level.
Yeah.
So that's just a
plea,
both a plea and an offer.
The power of narrative, I agree with that. Please.
So just to add to that excellent point, I think there's a real opportunity here with the reporting system that's been set up through HDR UK. At the moment, it's a very simple template, but actually having some use cases that were laid out in a standardized format that HDR UK could use to spread the good news would be incredibly important and would be a very powerful demonstration of what we were achieving.
Yeah, and it's not just for marketing purposes to commercial partners. This is essential feedback to the community to say, if you contributed your data, look what the benefit was for society from your involvement. If you want to build that sense of social solidarity around that, I think, that's a key part. Other comments? Marianne.
Thank you. Probably it's more of a question that I was wondering that whether HDR UK have looked at the other industries, like we mentioned, the banking or the other possible industries like mobile technologies.
Yeah.
And how we can learn from them, because there also has been a lot of commercial values that everybody had to come into the one table together. Thanks.
Yeah, I think it's always helpful to learn from other industries who've faced the same challenge. And of course, Dido alluded to some of the telco experience, and I know Mike in Leeds in the Personalised Medicine Health Centre, where you have a very strong fintech and legal tech, or whatever the term is, sector that's happening, but I think could be made more of. Please.
Thanks very much. I just wanted to pick up on the kind of consent and governance point. I think you absolutely have to get both bits of this right. So at the moment, I don't think our informed consent procedures can possibly anticipate some of the future uses and some of the ways that data might be used. And also, for quite a lot of us, if we're consenting to stuff, it's not necessarily because we've fully understood the terms and conditions and all the implications of how that data might be used. The risk is, if you rely fully on consent, you're putting a huge kind of ethical burden on an individual to take responsibility for understanding all of this information, and that information is not going to be complete. That being said, it doesn't mean there's not a role for it, but I think there's a good rationale for focusing in the first instance on getting the governance as robust as possible, so that even if I don't take a personal interest in what's happening to my data, I can know that it's safe, I can know that it's being used well and used properly, and someone is taking responsibility for the decisions around it. Once that system is better set up, more transparent, built in a more trustworthy way, then I think possibly down the line we might be able to shift more to a place where people may, make a decision to kind of opt into particular data uses or not. But at a whole national level system, I think at the moment, if we say no, we should put everything in terms of individual consent. We aren't going to be able to run a health service, and B, we're going to end up with some very skewed data. So let's not dismiss consent, but there's a really strong rationale for focusing on getting the governance bit right, and absolutely have patient, public, health professional participation in setting that up. But we can risk putting way too much on individuals if we think consent is going to be the panacea.
Thank you for that. Other comments? Well, we're just about exhausted. Seamus, did you have a point about the whole of the UK?
Yeah, sorry,
Can we just have a microphone, because I think it's an important point.
My name is Seamus O'Neill. I'm the Chief Executive of the Northern Health Science Alliance. We represent the big trusts and all the universities across the north of England, as well as the academic health science networks. And there's a bit of partly by design, but partly by accident of membership of the various groups, there was a complete absence of Northern speakers today. Speakers from the universities and the exceptional trusts we have in the north of England, and there is real leadership going on there. We've had a 4-year programme called Connected Health Cities, where we have done engagement at a scale that to be honest, the funders weren't expecting we would do, and we have learning at a scale that I think One London are about to embark on, and there's a lot of learning to be had there. So the absence of reach for this, into that community. I think Mike's here and I'm here, but apart from that, there's very few. 16 million people in the north of England. We've spoken about Scotland. We've spoken about devolved nations. If this ever starts to look like asset stripping data from the north, the entire thing can come down. If the jobs and the economic activities in the south, there's a big agenda in government at the minute to play to here. The levelling up of the economy across the UK, that's an opportunity for the hubs, I think, and
sure.
for the data infrastructure to play to, because that is live in government at the minute. I think
sure.
You can probably confirm that. But so that's one element to it. The other is the concept of clusters in the UK. I know Charlie and DataCan are reaching out to Northern Ireland, and there's a health and data cluster in Northern Ireland. There's one in Scotland, one in the West Country. So that concept of clusters, there are a couple of touch points there in terms of funding around this that government are listening to at the moment. I would offer those as a sort of a guide in terms of making the arguments.
Yeah.
But I would certainly, the plea is to, I'm not quite sure what the geographic equivalent of a mantle is. Not having all men on the panel, well, let's not have all Golden Triangle on the panel either. So,
okay. I think it's well made, and I think there's a general commitment here to leverage the whole of the UK in this effort. So if there are no other, one more question here, or comment here, please, just at the front.
Yeah, just very quickly, I just wanted to sort of follow up on the case studies. So I think a lot of things came up earlier about transparency, and putting together like a format, an easy to read format for case studies would be a really nice way to increase transparency and to give ownership to people that it is their data and this is transparency on how it's being used, and for them to feel some kind of connection, I suppose, with what's happening. The other thing that just kind of occurred to me a bit randomly was thinking about, like, sometimes your taxes, you get a letter through the post and it says this is from your local post saying, your local authority saying this is what we spent on this bit, this is what we spent on the environment, this is what we spent on schools. Well, maybe there's a case to do something like this about our data, and this is how your data, this is where where your data's come from, and this is how we've used your data as a way of kind of informing the public that and visibility and transparency for the public.
Exactly.
Estonia have done that very well.
Yeah. So thank you. Sorry, one. Yep. Can we have the colleagues?
Specifically on that, we're really keen to develop more data stories and more ways of talking about this stuff, maybe not using the term data, but just slightly more kind of engaging narratives and so on. On the kind of the dashboard or sort of pie chart approach, we've tried approaching NHS Digital previously to say, why don't you publish more of the kind of visually representative ways in which data is used, and had the pushback that there isn't a user need for this. So if there's demand coming from the community, by all means direct it that way. But I haven't had much luck in trying to push that.
Good. Thank you very much for that feedback and those comments. So if you'll bear with me, just a few personal reflections. I won't keep you long before we hear from Andrew. And the first is, it was mentioned several times this morning, but there are great grounds for optimism here. But this is a generational or once-in-a-generation opportunity, and with an opportunity comes responsibilities to achieve this. It was also very helpful to be reminded that this is about the future of health, and therefore we need to involve the future and engage the youth perspective as this work develops. Second, we discussed the need to have a more holistic view of value or values, not just the immediate commercial benefit. And of course, values is always in the eye of the beholder. I've already referred to some of the intangible benefits, such as breaking down siloed working, learning health systems, continue quality improvement, the cultural dividend that can come from accessing and using data to reflect on clinical practice. We've talked a lot about public and patient involvement and engagement needing to be an ongoing partnership and dialogue, but also to be involved in the process of decision making. This isn't a passive arrangement. This is a real partnership involvement. And I would argue that we also need to generate better data, evidence as to what best practice regarding public and patient involvement and engagement looks like, rather than just ticking a box saying we've spoken to these people and it seems to be working. We need to find out what is most effective for all parties. I was struck by one comment this morning about the role of intermediaries. And it's all very well us thinking we're constructing a framework and we can relate to our partners well. But if a citizen goes to a healthcare professional who either does not understand the potential values of data, or perhaps is minded to not welcome commercial involvement, that can completely threaten the trust that that individual has in the use of their data. And the reason I say that is through experience I had chairing a group at the Academy on how the public, how we all use scientific evidence to judge the benefits and harms of medicines. And as part of that, we did a survey of the general population, and we did a survey of healthcare practitioners, including general practitioners. And it was striking how I think it's nearly 80% of general practitioners viewed that clinical trial data that involved a commercial sponsor was not to be trusted. Now, if that's the messaging that comes to citizens when they go to their primary care service, that don't allow your data to be used if there's any sense of any commercial involvement, that's going to undermine the very best efforts to do this in a transparent, ethical, and well-managed way. So intermediaries are important, and we need to think about the constituencies we need to engage with to ensure the intermediaries' viewpoint is taken into account, but we are presenting rational arguments as to the way this can be taken forward. The social contract that's established as part of this process, I think, needs to ensure that we preserve the underpinning principle of the NHS, the commitment to equity. And as with personalised or precision medicine, there is a danger that this area could exclude certain groups we've already heard the point made about consent, for example. But it's the hard-to-reach groups and the socially disadvantaged that carry a particular weight of disease. And so it's incredibly important that we're capturing data on those groups, and finding ways to do that will be critically important. Penultimate issue I wanted to raise was the who benefits commercially. Is it the individual healthcare institution? What about the NHS at large? Because there's a system investment in this UK-wide infrastructure required to create a sustainable model here. So we need to be able to understand how those two requirements, incentivising institutions but also ensuring that the NHS as a whole benefits, is attended to. And that whole cost of developing a digital infrastructure and high quality data and its curation, without that we are going to be creating something which could easily not sustain public confidence. So I think it's a critically important issue. And then just to reiterate yet again, the gateway that's used for this needs to be transparent in all of its activity to sustain engagement of the partnership and public trust. So those are just some personal reflections on what I must say I found an extremely educational event, and I'm very grateful to all of you for contributing so fully. Before I hand over to Andrew to outline his thoughts in terms of how HDR UK responds to this agenda going forward, can I thank my HDR UK colleagues, the Academy, for hosting us and for, through James and Emma, supporting the development of this programme, and my CASMI colleagues, and in particular Michelle Craft, who's played a major role in keeping us on track. And just one final plea: in your pack you will have found a diversity form, and I'd be grateful, the Academy would be grateful if you would complete that if you're minded to do so, so that we can capture data on that important aspect. But with that, I'll hand over to Andrew for the next steps. Thank you.
So thank you, John, and thank you for moderating so well. So I won't keep you past 6 o'clock, I promise. So a few reflections from me. So firstly, I think we've had a terrific day, and everyone's contributed, and it's been great. And that's the way it has to be. You know, no institution, no sector has got the answer to this. If the UK clearly is going to excel, it's going to require, you know, a team and collaboration arguably never seen before that brings the publics together with ethicists, social scientists, computer scientists, lawyers, biomedical scientists. So it is truly a grand challenge. When I came today, I thought, goodness, this is hard. And standing here, I'm thinking, this is very hard. So, I don't know if you've ever been hill walking in the Scottish hills, because you get to the top and you think, I'm there, and you're about to put your stone on the cairn, and you look up and there's another hill ahead of you. So it's a bit like that. So we're in the foothills of where we need to go. But I would argue, you know, there is a huge opportunity here for the UK, and it has to be, building on Seamus's point, it has to be UK-wide, because the formula here is local, regional, national. And it's hopeless competing between regions or the national, regional, local debate. So how do we create an ecosystem that allows people to participate regardless of where you are? So this is hard. As someone said, the art of simplicity is the puzzle of complexity. So we are going to try and solve the puzzle of complexity. And I think, you know, colleagues and myself at HDR UK, we feel very privileged to be in this space, but just to be clear, we don't want to control any data at all. What we're trying to do is join the dots to really drive interoperability. The ability, when there's a clinical need or a research need, to work across systems with no additional effort. Because currently, whether it's for care, for research or innovation, the additional effort is huge. You know, I had a PhD student who was waiting 3 years to access data. 3 years. And as you're supposed to do a PhD in 3 years, it's tricky. And it was approved because it was perceived to be in the public trust. But that's no way, that's people's lives. So how do we maintain the integrity of this trustworthy UK health data research ecosystem in a frictionless way? And that's a grand challenge. And I was reflecting, if we're going to do that, I think it is going to be about values, and we need to hold ourselves to account for values. And John's articulated, and many colleagues have articulated them very well today. So this notion of benefit share, really being clear on benefit share and articulating that better. What is in the public benefit? As Jonathan said earlier, ideally we'll all be better off in ways that are consistent with the NHS mission, and additional value needs to be fairly distributed. So I think that's the first value. The second is this one of equity and reciprocity. So equity in terms of making sure that what we do doesn't disadvantage groups, whether that's geographical groups or certain societal groups, but reciprocity, and I think this is where we need to be much better in how we work in partnership with the publics, especially around shared decision making about what we do with information. The third one is transparency, and I'm delighted. Hello, the folk on WebStream, because it's great. We've been open today, and I think there's been scores of people online, which is terrific. But taking a phrase from our Singaporean colleagues, they say that neither reputational concerns nor commercial interests are alone sufficient to outweigh the value of transparency in how public-private partnerships work. And I think that's something that we could reflect on. So I would argue this is going to be hard. It's going to be a sort of learning journey. But if you look at the best performing health systems in the world, yes, they focus on quality, the 6 dimensions of quality. Yes, they have good leadership, good governance. But they've got 2 other things. So if you go to if you go to the Mayo, if you go to Duke, if you go to Jönköping, they have whole system intelligence. So they have, often in real time, the ability to track journeys of care of citizens from primary, secondary, tertiary, and increasingly social care. And secondly, and Brian alluded to this, they have the capability to run analytics and data science to learn. So how do we use information to learn, to improve, so that we improve outcomes of care, but also the patient experience? And that's the real opportunity that we have. It is an opportunity, and actually we've got a track record of doing it not very well. We've all got stories of how we don't do this well. So thank you for coming. You're now wrapped up in this, and you'll be doing this for the next 20 years, which is great. We're keen that we do move at pace. So what we're going to do, we're going to have a summary of this meeting within 4 weeks, and we should try and publish that as well and publicize it. We're going to work with colleagues at NHSX across the devolved administrations, OLS, so that everything we do feeds in seamlessly to their deliberations. We're going to pick up what we've said today and try it out, and try it out with the hubs, and all progress will be openly available on the Alliance website and on the gateway, because we want to do this in an open way. We have twice yearly meetings of the Alliance. The next one's in February, so it's too soon, but the next one's in October, which is, I'm officially announcing, is going to be hosted in Manchester. Will you host us? Right, there we go. So
So we'll meet in the north in October, when, pardon? Yes, we haven't discussed the invoice yet. So we will reconvene again. That will be an open meeting, so we'll monitor progress that we've made over 2020, and we're going to do our best to work in partnership to make real progress in the public benefit. So that's our challenge. I think it was Mandela who said, "It always seems impossible until it's done," which I think is, this probably will never quite be done, but we can certainly make huge amounts of progress. So can I thank everyone? So the AMS CASMI HDR team, so that's James, Michelle, Rebecca, Carol, Christopher, and can I thank especially Caroline, who has actually, she's been an absolute star and has been an architect of many of the things that we've seen today. So a huge thanks to all of them. But most importantly, thank you, and let's go and do good stuff together. So thank you very much.